a lot has changed since the transparencies here were prepared, and so I'm going to deviate a little bit from them, and bear with me if I'm not following what's written. Couple things. Number one, there are two changes that took place July 1 to the plan, and Advantage is a fiscal year trust, and therefore the changes for us take place on a July 1, not January 1. But effective July 1, prescription drugs went to, preventive part of it became a no cost to the participant. For the generics, the participant is able to obtain prescription drugs, this is birth control, if they are non-generic only with medical necessity for a non-generic brand. And the second thing is part of the preventive services that has come out of the PAPACA Obamacare is that women are supposed to be provided additional services with lactation and pumps. And so the plan is compliant with PAPACA. It provides a manual breast pump as part of the no cost sharing preventive services, but the trustees also voted to provide an additional benefit for a participant that doesn't want to get a single manual breast pump. They can get a different model, and the plan will pay up to $200 for that benefit, subject to deductible and co-payments, but it is outside of the normal 100% preventive. So those two things took place. The rest of PAPACA in terms of changes for Advantage really kick in, or will kick in July 1, and there are a lot of changes coming. Everybody knows the exchanges opened up. Today's Wednesday, so they opened up on Tuesday. I've spent a little bit of time, I could say, actually, on the exchange, looking at what's out there and how you enroll. And
did you get signed up?
No, didn't get that far. But it is pretty interesting. And I thought maybe one of the things that I would do in lieu of just going through the what we know and don't know, which is on the next transparency, is maybe I want to give you the information on the basis of what I do know today, which we didn't know 3 weeks ago. I can tell you that the exchanges are up, they are running, there are glitches, but they are expected to be worked out. The employer mandate, which is the pay or play, I think we did a webinar earlier this year on that, where the penalties, the tack hammer, sledgehammer penalties, the $2,000 or $3,000 penalties that apply to employers that have 50 or more full-time employees. Those penalties have been delayed until 2015. And so for employers, it's kind of a different game in terms of understanding what they're going to have to do, because they don't have that penalty attached to their decisions this year or for 2014, but they will come back in 2015. The individual mandate has not been delayed, and that's part of that activity going on in Washington. I was trying to think of a better word for it. Whatever they're trying to do, part of what the House is trying to put in is a delay of the individual mandate, and the administration does not want to delay the individual mandate. So whereas employers will not be penalized for not complying with the offering of health care that is affordable and of a sufficient coverage and has the minimum value, the individual is technically going to be penalized if they don't have health insurance in place for 2015. The exchanges are open. I think the plans that I looked at, I glanced briefly at the Texas plans, glanced at the Oklahoma plans. The deductibles are fairly high. The out-of-pocket exchanges are pretty high. And I think it's kind of an interesting scenario when you really start looking at it. My husband's getting ready to have surgery or have something done on his knee. And so I, consumer-driven person, said, well, when you go get your MRI, you need to ask him how much it is. And so yesterday he told me how much they told him it was, and so I went on my little phone and I was looking to see what the fair price should be. Now he's Medicare, so he keeps telling me it doesn't matter, but I go, it's out of my pocket because I'm still working and you're not. So I did this, what's the fair price? And it was really astonishing because the first thing that came up, it said, if you have health insurance, it's your copay. That's the cost. If you don't have health insurance, they gave me a range of 1,000 to 5,000. So my blood obviously rises and my temper doesn't. I don't hold my temper well, but I'll tell you that. And I thought, how ironic. What they're telling people is the cost of the procedure is your out-of-pocket copay amount, and that's what's reasonable, that's what's fair. And I thought, they missed the whole boat. But when you go on the exchanges, that's exactly what is happening. They're saying your premium cost less the subsidy is this. Your copays, your out-of-pockets, that's the cost of health care. And nothing is going beyond that to say, what does it really cost? I mean, not what are you out of pocket? What is the cost of that service? What is the cost that you're getting? And they have no means to quantify it. Why they can't quantify it, I'm not sure I can tell you just yet, but they're not. The exchanges have what is considered minimum value plans, and for those of you that have looked at them, you're going to see that there's bronze, they're called metal tiers. There's a bronze, there's a silver, there's a gold, and a platinum. The bronze is basically a 60-40 kind of copay, cost sharing. The silver is the 730, and that is the one that is used for benchmarks in terms of what people will get as subsidies. The gold and the platinum obviously get better. They're an 80-20 or a 90-10. Part of the way that the employers are going to comply with the employer mandate that was delayed until 2015 is to provide what we call a minimum value plan. And I'm going to deviate here a little bit because I think there's been a lot of confusion. The last item on there says the exchange notice will be mailed. The exchange notices were mailed. And the exchange notice, just so that you know, that what you got was an exchange notice that is, quote, a model notice that the Department of Labor put out in terms of what they think employers ought to provide their employees. Now, the exchanges are designed to gather people who have no insurance. So to me, it kind of didn't make sense why employers are going to be required to provide notices to employees who already have health insurance to go figure out what they could get on the exchanges. And the only thing that is attractive is they're trying to suck employees out of employer plans on the premise that the cost to them will be lower because they will get a subsidy if they are within the subsidized levels, which basically is going to pick up individuals between 100 to 400% of poverty level, and it's based on the number of individuals in their household as to how they determine it. So when the exchange notice went out, some of the questions that came back kind of surprised me, and some of them I kind of went, okay, I need to go back to the beginning on some of these things. The exchange notice went out, and our recommendation is that you go ahead and provide it. You are not penalized if you fail to provide it. The Department of Labor did not issue their guidance on the fact that there is no penalty until I think just a few days before the October 1 deadline that had been created. The notice is what tells people where they can go get the information, what telephone number to call. Most of the exchanges are up, but they're not necessarily operational to where someone can actually enroll. Sometimes they're having to print forms and then call somebody to actually enroll. Wait times right now are kind of crazy. The enrollment period is between now and March 31, so it's a 6-month time period during which they have to actually log on and buy health care. And I think that's going to give people a little bit of chance to understand it. As you can imagine, I peruse the news quite frequently in this area just because there's so much that comes out. Sometimes not in the official norms that I'm used to seeing, and sometimes you got to watch what they're tweeting out of some of these departments to figure out what regulations are coming down the pike. And I saw something yesterday that just really was kind of interesting. There was an interview that was done I couldn't even tell you what station or who it is because I've been flipping between CNN and Fox to see what the variations in presentations are. But there was a query that was done of people just walking on the street, and they said, would you prefer having the Patient Protection Affordable Care Act or Obamacare? And the response was almost unanimously, well, the Patient Protection Affordable Care Act. I don't want the Obamacare Act. And I sat there and I went, wow, they're one and the same. And that level of not even understanding what is out there, I think is part, for me, is frustrating, disappointing at some level, but there is a tremendous amount of misinformation and there's a tremendous amount of no information out there, so that when people are asking questions, and your employees will be asking you questions because they will go on the exchange to check out prices, it's kind of shocking sometimes that you don't realize that they really don't know much about what PPACA, Obamacare, ACA, whichever name you prefer to use is. It is one and the same. So that being said, let me just give you a couple of things to make sure that everybody understands. AHP is going to have a plan that is going to be probably a 60-40 plan, which is not as generous as any of the plans currently in place. It is going to be in place sometime during 2014. I can't quite figure out what the best timing of it is. We don't have to have one at all until July 1 of 2014, And that plan is really 2014, and with delay of 2015. The plan is really intended to enable employers to provide the lowest cost option to their employees. And the purpose of that plan is to ensure that as an employer, if you're over the 50 employee, where you're subject to the pay or play penalties, that you have offered your employee a plan that is affordable, meaning it's no more than 9.5% of their taxable compensation, not their gross compensation, but the taxable compensation, box 1 on the W-2s. And as long as an employer, you are offering a plan that meets the appropriate coverage level, provides at least a minimum value of 60%, meaning that the plan overall is going to pay at least 60% of the overall cost, and it is no more than 9.5% of their taxable compensation. If that individual goes on the exchange and gets a subsidy on the exchange and gets a plan, as an employer, you're not exposed to the penalty because you have complied with your portion of it in terms of making that coverage available to the employee. You don't have to make them take your coverage, you have to offer it to them. Once you offer it to them, they can turn it down and they can go on the exchange. Technically, if you're offering a plan that is less than 9.5% or no more than 9.5% of the taxable compensation, that individual is not going to be eligible for a subsidy on the exchange. Now, that doesn't mean that the individual can't get a subsidy on the exchange, because the exchange measures eligibility for subsidy on a totally different level. They measure it on the household income level, the adjusted household income based on their tax return. So it's household income, actual household income for the calendar year in which they get the exchange-based plan. And so our goal at the AHP level is to ensure that you have a product that is going to offer the benefit that meets your obligations so that you as an employer are not on the hook for the penalties. Whether the employee chooses to go on the exchange because their household income qualifies them and they therefore get a subsidy on their own on the exchange, that's an individual choice that each one of them is going to have to make. I'm not convinced just yet that even with the subsidies, they're necessarily going to end up in a better place, because they will have some cost and they will have some out-of-pocket, and what they pay is always going to be after tax, not a pre-tax contribution like most employers allow their employees to do today. One of the questions that came back on this minimum value plan for sometime in 2014 is, when are we going to have a skinny plan? And I thought, okay, I need to make sure that I clarify what a skinny plan is, and it was listed in what Megan blasted out in an email the other day on a series of just questions and answers. When you hear people talking about a skinny plan in the media, what they're talking about is a plan that is designed to provide basically preventive services only. It is a plan that has, from a scope of benefits, a reduction in benefits that is drastic in comparison to any of the plans that Advantage offers on any of the plans that are out there. It is a very, very limited scope benefit, and the IRS has said that that's sufficient to say that the employer has what they call minimum essential coverage, and therefore as long as you offer this skinny thing, you're not subject to the high penalty, to the penalty that applies to all of your employees, but you can be subject to the penalty that applies if that individual goes on the exchange and gets coverage, because they're not getting a minimum value plan. AHP is not going to have a skinny plan. We're going to go with a minimum value plan, but not a skinny plan. And the reason for that is a skinny plan doesn't protect you as an employer from the penalties that will come into play when the employer mandate is enforced in 2015. So if you hear talk about the skinny plans, we're not doing that. We are going to do a minimum value plan. All of our plans are compliant today. And for all of the employers on AHP today, none of these penalties apply to you today. And I just want to make sure that everybody's kind of clear, because the questions, keep coming up as to whether they are or aren't.
Well, and all of the Advantage Health plans meet, they greatly exceed the minimum value requirements as far as coverage.
Yes.
And so our idea of a minimum value plan would to be able to provide a lower cost option to the banks to still fulfill the minimum value requirement.
Yes, and what it will do is it's going to shift more cost to the employee, which is what's going to make it more affordable.
Yeah. Would just be one that the bank would just offer that, the employees wouldn't have to take it.
It's really not, it's not designed to be a win-win. It's really a lose-lose deal in my book. But we will have it for employers that need it. Would you go to
Sure.
the next one? Here's what we don't know, and I wanted to just kind of talk about a couple of these things because it's really kind of interesting to see. The contracts with the exchanges were not signed until the end of September, and some of them, I think, have not been 100% finalized, and that's why when you see in the media that they have some issues with the pricing, part of that is because they didn't have their contracts in place to know what the costs for the policies are until the very last minute. The exchanges are up. The large percentage, I know in Oklahoma and in Texas, of individuals who are not insured, who are intended to be pulled into the exchanges, happen to be Hispanic and Spanish-speaking individuals. The Spanish version of the exchanges will not be available until at least November 1. Not sure why they don't have them open, but the Spanish version is not available. So if people wanted to get the information in Spanish, they're going to either wait until October 1 rolls out and go on the exchange at that point on the website to get the information, or they're going to have to talk to individuals and hope they get the Spanish-speaking one to get the answers. The pricing is out there now. I think it would be interesting for you to just log on. You can log on to if you just Google Texas exchanges, it'll send you to a federal site, or you can go to the site that's on the exchange notice that you passed out to employees and look at what the pricing is. In every state, the pricing is basically based on regions. It's not one price for the state, so it's divided into states, and what happens then is that when you enter your zip code, it sends you into the pricing for the region that would apply to you. There are very few things that are asked just to get the basic pricing, namely it's your age, your sex, and whether or not you have other coverage that you're replacing, or whether you're a full-time student. I mean, they're very minimal pieces of information to go in and kind of identify. If you get to the point where they're asking for household income and you put your household income, it'll tell you whether you will or won't, you might or might not qualify. And the might not qualify is because they really don't have those numbers fully integrated, and that is one of the glitches that they've got with the exchanges right now, is that when people sign up and they're getting the premium cost for the health care, the subsidies are not being calculated properly yet. I think they'll probably work that glitch out here before the end of the year, but it's a glitch. The things to watch for. So what we didn't know today, I do know some of those answers. Things to watch out for. There is a marketing blitz. I've been on the government health sites to look at some of the marketing materials, and believe it or not, they actually have canned marketing materials that are presented out there that people can just take and download. And the ones I looked at were really aimed at students. They were aimed at schools providing it to their students. There was one that was a business card with the front of it saying, something like, do you have health insurance, and the back of it giving the exchange information. And the idea is that the schools will print these things up and distribute it to their students so that the students can take them home and give it to the parents. The entities that are responsible for the navigator systems they were actually announced in mid-August. The money was granted to them for their education. There's some real concerns on the navigators because there are some things that are missing from the procedure as to who's eligible to be a navigator. There's very little that's being done to really do background checks. The information that these people have is obviously very extensive because they're going to have your name, your date of birth, your social security number, and if you want to do an identity theft, it certainly would be easy to get based on the information that they gathered just from the application. There's some pushback on people saying, no, don't do background or criminal checks on these people. You need to just let them work. The entities that I've seen that got grants to do the education for this were almost all community organizations. They were entities that were designed or worked very highly in marketplaces designed to enroll people on Medicaid. The requirements for the training were supposed to be 20 hours. The timing of when they started it and now that the exchanges are open is a very short window. There is no monitoring of the education process to make sure that people have actually got it. So there are glitches in terms of the people that are going to be doing providing the information that is going to help individuals supposedly log on and be able to enroll on the system. The other thing that is out there that we do know and is kind of still up in the air, I think for 2014 it isn't going to be in play, for 2015 it might be in play, is there is no mechanism right now to verify whether someone is or is not eligible for these subsidies. They're basically using a fair representation. If you tell them that's what your household income is, that's what they're going to work with, and that's how they're going to determine whether you get a subsidy or not. It won't be until tax returns are filed after the end of 2014, which basically means for most people that are wanting refunds, they're going to file them in the beginning of the first 2 months of January, February of 2015. It won't be until that actual number is computed that they will be able to figure out whether or not the person really was eligible to receive the subsidy. And some of the things that can happen may just be unintentionally misstated. For example, you get someone who is on a part-time job today, and or in January when they sign up, and they get a full-time job in March. Their household income changes significantly from where they anticipated it was going to be, because when they were asked what was your household income, they gave the income at the point in time that they were at. And now that they've got a full-time job, they got a lot more income. And I think the shocker is going to come out in 2015 when it becomes evident that there are people who got subsidies that shouldn't have gotten subsidies. And the unanswered question, and I really don't know exactly what the IRS is going to do or how they're going to do this, is whether or not they'll actually initiate a collection system to get these monies back. I guarantee you that if there are refunds due, I think they will definitely offset them. I think if it's going to be a collection mechanism, it will be a public relations disaster to suddenly start sending collection notices to people that thought that they got this health care subsidized, and now they actually have to pay some of that money back. I think that's part of a big glitch that is going to have to be worked out, and as of right now, I don't know what the answer is. On the pay or play side of it, in terms of trying to identify whether or not an individual has coverage, one of the things that is going to happen, and I've seen some of the regulations, I'm not quite ready yet to really put anything out because I think they will change significantly. One of the things that's going to happen is employers are going to be filing informational returns about every employee that they have, every dependent that is covered under their health plan, what coverage they offered them by month, and then you're going to be asked what the cost was by month so they can figure it out. Now, those forms won't be filed until calendar year 2015, for calendar year 2015, which means that that information won't be filed until, won't really be available until 2016. So the idea is that between the information that the employer provides to the IRS, the information that the individual provides through their income tax return to the IRS, that somehow they're going to combine that information and coordinate it with the exchanges, which have been outsourced for the federal exchanges like Oklahoma and Texas. It is not the government that is running it, it has been outsourced. And they're going to combine all this information into the exchange database with HHS to coordinate it and figure out whether people got subsidies that weren't supposed to get subsidies or whether they got what they were supposed to get. The real concern that I think is popping up is the exchange of information is fairly significant. The systems that are in place to capture the privacy of the information and ensure that it does not get misused are not quite there. They've already had some glitches with information on some of the exchanges where people were pre-enrolling, where the data has been released without any protection. And like I said, when you sign up and you put all that information on the exchanges, there's enough for, certainly enough for any kind of identity theft if that is going to be the use for it. And they do not have those glitches worked out. So what we don't know as of today is how they're really going to resolve some of those things. The expectation for next year is that they will pick up a lot of people on the exchanges. It won't work unless they actually pick up a lot of young, healthy individuals, because those are the individuals that are intended to subsidize the cost of the older people. The people that need health care are what I would call an adverse selection. Those people will get on, and I can guarantee you that their costs will be paid either out of their pocket, or there will be agencies that will be helping to pick up the cost so that they can get the coverage for them and lower the agency's costs. And those individuals are the people that need the health care because they are sick and they are users of the system right now. So they've got to have a large portion of the healthy part of the population enroll in order to make the dollars and cents work. I don't think they have any idea just yet of what the real cost is. I don't think anybody has any idea of what the cost of the subsidies are. I don't think the insurance companies really have a sense of what the cost of actually providing the coverage is going to be. I think all of that is going to be kind of up in the air, and it's going to be sitting there until somebody can start gathering data, and I don't think it'll be done until the actual coverage begins, which won't take place until January of 2014. With that in mind, one of the things that we've talked about in the past is the PCORI fees and the reinsurance tax. The PCORI tax, of course, is the $1 a belly button, and that's in play already. For Advantage, we will pay based on our fiscal year that ended June 30, 2013. The reinsurance tax is the one that is the $5.25 a belly button for each person covered, not by employee, per belly button. And that money is going to be collected by HHS towards the end of 2014 based on belly buttons covered in the plans, regardless of what the plan year is, starting in January. That's the money that is going to be used to give back to the insurance companies to help them subsidize the adverse selection that's anticipated on the exchanges. The numbers were fixed statutorily when the laws were drafted. I think it's pretty clear that the expectations in terms of the estimates of the cost of Obamacare when it was initially priced out in 2010 is nothing like what it's getting close to in 2014. It certainly is a lot less, but the reinsurance fee is a statutorily fixed amount that is going to be used, and it is, it's up in the air as to what's going to happen when there's a shortfall that is far over and above what is expected to be collected with these reinsurance taxes, because insurance companies are going to have one of two options. Year one, they're going to have to eat the loss. Year two, the rates are going to go up. The last thing I want to say is in looking at, and you've seen the memo because I drafted a memo that went to the banks that addressed this. When you're looking at the success of an exchange plan, the model that we have that is historically available for us to compare is Romneycare in Massachusetts. And in Massachusetts, as the memos that the article I wrote indicated, they do have the lowest uninsured rate. They also have the highest cost for health insurance. And their biggest problem today is access. They have people that are waiting to get onto the services because there just aren't enough providers. The exchange is kicking off January 2014. If they have any level of success at gathering people to actually enroll into these exchanges, leaves the same kind of questions as Romneycare does. If you flood the market with 10 million new bodies, not the 40 million they're talking about, just 10 million new bodies, and you have a decline in the number of physicians who are treating these people, and you don't have new facilities, you don't have a massive group of new docs that are going to be providing services, I mean, to me, the picture's pretty clear. Your volume goes up, the number of providers didn't change, access is going to be slower. In some cases, I think it's going to change. My prediction is that we're going to have a two-tiered system, and I think the two-tiered system is starting to evolve, and I think Dr. Smith clearly indicated his version of it, because I think he is on the side of that second class, and the second class is going to be its access to individuals who are willing to pay for it or who have plans that are willing to pay for it, and it is not going to be the insurance companies that are providing it through the PPOs, because they're not going to have the capacity to provide the services. So those who have to go on the exchanges to get health care will have longer waits and probably will have a little bit of rationing, which I know is an ugly word, but I think it is going to happen, and I think you're going to see it in 2014. And I think the mechanisms are in place to get part of that going. Those who have the self-funded plans with employers that are willing to pay for the cost of the real cost of health care, not the insurance premiums, but the cost of the health care itself, like AHP does, are going to have much better access to providers, because they're not going to be on the same, they're going to be on a different level. And I think that is, when I look at what I don't know the answer to it. My gut tells me that we will have an access issue, and this time next year, I think we're going to have some updates, and I'm going to say, man, did I blow it, or boy, was I right.
Yep.
I wouldn't tell it to you unless I thought I'm right. So we'll wait to see.